Good morning, everyone. Thank you so much for joining us for Emory Healthcare's Health and Wellness Speaker Series for DeKalb County School District employees. This morning, in honor of the last day of October, we have a really great presentation lined up that we're calling Breast Cancer 101. We're lucky to have two great speakers with us today. We have both Dr. Demetria Smith-Graziani, who is a board-certified medical oncologist with Emory's Winship Cancer Institute. She treats and sees breast cancer patients at both our Clifton Road campus as well as our Winship Cancer Institute at Emory Midtown. She got her medical degree at Tufts University in Boston and also got her master's in public health in epidemiology at UT Health School of Public Health in Houston, Texas. And she also has a role as an assistant professor at Emory University School of Medicine as well. And then we also have with us today Lizzie Huckaby. She is a breast cancer clinical research nurse with our Winship Cancer Institute. And they are gonna kick us off and share some really great information about breast cancer with us this morning. And yeah, thank you all so much for joining.
Thank you for having us. I am going to share the screen. And start the presentation. Okay, so again, thank you all so much for joining us. We're gonna just talk about the basics of breast cancer, and please, any questions that you guys have, and just let us know. All right, so we're gonna talk about what is breast cancer, how do I understand my personal risk of breast cancer, how do we diagnose breast cancer, what are the types and stages, and then how is breast cancer treated? All right, so starting off with what is breast cancer? So when we're talking about cancer in general, we're talking about cells that started out as normal cells in your body that then at some point mutated and started stopped listening to the signals that the rest of your body was sending. So breast cancer is really the group of diseases where the cells in the breast tissue change, mutate, and then start dividing in an uncontrolled manner. And most of those breast cancers are beginning in two places. So either the lobules, and I don't know if you can see my pointer, but the lobules are the milk glands, and then the ducts are the tubes that connect the milk glands to the nipple. And so you might hear people talk about whether they have a ductal cancer or a lobular cancer, and that's what they mean. Lizzie, you want to talk about risk? Okay. Lizzie, you want to talk about the risk of breast cancer? Oh, yeah.
I'm 3 years in, and it's like I'm new here. So breast cancer is our most commonly diagnosed cancer in women worldwide. We're going to see 1.8 million new cases each year, and unfortunately, over 400,000 deaths related to breast cancer. You can see the numbers here reflected for the United States and then for Georgia specifically. Over the last few years, breast cancer has become the leading cause of cancer death in the United States, past non-cancer. So Dr. Smith-Graziani, I'm thrilled that y'all are here today. Early awareness and detection is the name of the game, and hopefully we can help answer some questions that you guys might have today. And we'd love for y'all to share it with your colleagues and your community so that we can keep taking a swing at this.
Yeah. So we know that approximately 13% of women are going to be diagnosed with breast cancer sometime in their life. So that's about 1 in 8 women. And it's usually diagnosed between ages 55 through 64. And about 3% of women will eventually die from breast cancer. However, we've gotten a lot better at treating it over the years. So the rate of death from breast cancer has declined 36% from 1989 to 2012. And that's mainly due to improvements in early detection, talking about screening, and then as well as treatment. And then 91% of women now survive at least 5 years after their diagnosis. Really, we now have over 4 million women living with breast cancer in the US in 2022.
Dr. Smith-Graziani, we've gotten a question about why the cells change and what we can do as individuals to reduce our risk.
Yeah, that's a great question, and actually really perfect timing for this. For most folks, the reason for why the cells change is just chance and luck, because every time that cells in our body are dividing, they are making copies of their DNA, so that they can then duplicate and create new cells. And every time you make a copy, you have a chance of having basically typos in your genetic code, and those typos are mutations. And we have things in our body, we have proteins and systems in place that are supposed to find those typos and correct them, but sometimes we miss them. Sometimes there are too many typos and we can't keep up, right? And that's when we develop the mutations that make a cell cancerous. So when we're talking about how can we decrease our risk, we think about things that are modifiable and non-modifiable risk factors. So here are the list of factors that are known to increase breast cancer risk. The ones in top and the bold are the ones that have a higher level of association, and then the ones in gray down below have sort of a lower association. So the biggest things, so if you have a history of certain precancerous lesions, you might have heard of things like atypical hyperplasia, like atypical ductal hyperplasia. Those are things that can increase the risk of you having a future breast cancer. Many people have heard of the BRCA gene and BRCA mutations, and there are other mutations as well that are associated with an increased risk of breast cancer. And usually when you talk to your doctor about your family history of breast cancer, or at the time of your diagnosis, depending on the type of breast cancer you have and your family history, we may recommend that you see a genetic counselor and consider genetic testing to see if you have one of these mutations. I mentioned family history, so having close relatives, meaning parents, grandparents, children, siblings who have had breast cancer, as well as certain other types of cancers like prostate cancer, pancreatic cancer, melanoma, ovarian cancer, can be associated with some of these mutations that increase the risk of breast cancer. And also, the older we get, the more likely we are to develop these mutations over time. So increasing age is always associated with an increased risk of breast cancer. And then another potential risk factor is being exposed to radiation at a young age. So there are some people who have had treatment maybe for another cancer like a lymphoma in the past, where they had to have radiation to the chest area. And because their breasts were exposed to that radiation, that's going to put them at a higher risk of developing mutations in the future that could lead to cancer. And then there are these other factors that have some association, but not to the same extent. So obesity, specifically in postmenopausal women, is shown to be associated with an increased risk of breast cancer. Basically, the longer amount of time that you are having periods and having cycles and being exposed to fluctuation of your estrogen, that increases your risk. So people who start their periods at an early age, we call that menarche, or who go into menopause at a later age, do have a slightly increased risk. Because when you're pregnant, you're essentially shutting down your ovaries for that amount of time that you're pregnant. People who have their first child at an older age do have a higher risk. There's also a risk associated with excessive alcohol use. It's hard to pin down how much. We don't really have a safe level of alcohol. But we generally use, the standards of excessive alcohol use that have been recommended by, the CDC and public health organizations. Dense breast tissue. So you may find that when you have a mammogram that they talk about your breast tissue is dense. That makes it harder for us to sometimes find a cancer in a mammogram, but there is a small association as well with increased risk of breast cancer. And then use of long-term use of hormone replacement therapy. So if you are in menopause and taking estrogen or progesterone to help with the symptoms of menopause, usually your doctor is going to have sort of a cutoff time after a certain number of years where they would want you to be getting off of that because there is that association. There is a small association with type 2 diabetes as well. And then recent hormonal birth control use. So because the birth control pill does have estrogen and progesterone in it, that exposure to estrogen can increase the risk. However, it's a mild risk that returns to baseline about 10 years after you stop using birth control.
There is one of the institutes, we work with the Dana-Farber Cancer Institute as one of our cancer prevention partners. They've got a great online assessment tool that I'm going to put in the chat called MyRisk. That can be really helpful both to gauge kind of your own individual risk, but also to guide the questions that you might ask your healthcare provider to help make sure that you are being assessed at the right time over the course of the month. So I'm going to drop that in the chat for everybody.
Perfect. So what can help? I know we just talked about a lot of things that increase the risk. What might actually reduce this risk? So there is an association with breastfeeding and a decreased risk. So for each year of breastfeeding, there's about a 4% decrease in the risk of breast cancer. Again, that's somewhat related to, the hormonal changes that occur during breastfeeding. Physical activity can help reduce the risk. They think maybe it's because it reduces the levels of estrogen that are in the blood. And we're going to talk about different types of breast cancer. We're talking about estrogen a lot. The most common type of breast cancer is one that feeds off of estrogen. It can exercise could potentially lower the risk of breast cancer by 10 to 20%. We don't have any data that really strongly links a specific diet or specific supplements with your breast cancer risk. And I know that is something that people ask about a lot. We always recommend people having a well-rounded diet of lots of fruits and vegetables and lean protein, but we do not know at this time that a specific diet affects one's risk of breast cancer. So I'm always going to talk a little bit about disparities in breast cancer because that is my research focus. So when we're talking about risk, we want to know how that risk varies by different factors, specifically race and ethnicity. So in breast cancer, we see that Black and Native American women have a lower incidence of breast cancer in the U.S. than white women, meaning that they are less frequently diagnosed with a breast cancer. However, they're more likely to die from breast cancer compared to white women. And we also see that Black, Hispanic, Asian and Pacific Islander and Native American women are diagnosed on average at a younger age compared to white women. Also, related to this higher mortality for Black women, there are fewer breast cancers in Black women that are diagnosed while they're still curable when compared to white women. When you look at how many people are still alive 5 years after their diagnosis, or that 5-year survival rate, among Black women, it's only 78% compared to 90% among white women. Why does this happen? It's multifactorial, a lot of different factors, but the general categories that we think about are the biology of the cancer itself. We have found that Black women are more likely to be diagnosed with a type of breast cancer called triple negative breast cancer, which tends to be more aggressive and has less treatment options available, and is diagnosed at a younger age, usually in Black women compared to white women. In addition to all of these biological features, we also know that socioeconomic and structural factors play a role, because Black women are less likely to see their primary care doctors regularly, which means they're going to be less likely to undergo screening mammograms. So they're going to usually be diagnosed later and at a higher stage compared to white women. And then once the diagnosis is made, usually Black women tend to have more delays in their care. So what is the amount of time it takes from you having an abnormal mammogram, from getting in to get a biopsy, to seeing an oncologist, and to starting treatment? We find delays, at every point. So there are a lot of different factors at play. So how do we diagnose breast cancer? A lot of times breast cancer is really asymptomatic, and I think that's the thing that scares a lot of folks. That's one of the reasons that we really recommend getting your screening mammogram, because the mammograms can detect the signs of breast cancer earlier than we can see them on ourselves, or even your doctor can see them on a physical exam. However, when you do have symptoms, you may feel a lump or a mass in the breast, or a mass or some fullness under your arm. The less common symptoms might be changes in the skin. And this picture here is what we call peau d'orange, which is French for orange peel. And so it's this dimpling and thickening and swelling and redness that occurs in the breast, and can sometimes be a sign of the breast cancer invading the tissue in the skin. You could also feel some pain or heaviness in the breast. And then we also ask about changes in the nipple. So you'll see as well that this nipple is slightly inverted. So you can have some inversion of the nipple. You can have discharge from the nipple. You could have scaliness. Any sort of changes really in your normal breast skin, the nipple, anything like that is something to bring up to your doctor. So again, we want you to get your screening mammogram, because we know that if we find the cancer earlier, we're more likely to be able to cure it. And we have the data to back up that if you're getting screened, you're less likely to die from your breast cancer. So we talked about a mammogram. I think a lot of people have a fear of mammograms itself. So for those who may not have had one, I just put up this picture so you know. I think from our patients, one of the biggest complaints is that it's not very comfortable because they are squeezing that breast. As of right now, this is the best tool we have. They kind of have to try to get it as flat as possible. And so you can see that the breast kind of gets squeezed under this machine. They're looking for calcifications in the breast. And you can see this picture over here. This area, that the white area is that area of sort of calcification. And they're also looking, is it asymmetrical? So does one breast look different than the other? Especially in people who might have dense breast tissue, do we see something that looks sort of abnormal?
One of the reasons that it's important to get your mammograms, often and according to schedule, is because breasts are different, right? And so there is a certain amount of asymmetry that can be normal. There are all kinds of different variations of normal. And so it's important for us to have a baseline as your provider. So at 40 or 45 or 50, whenever you're supposed to start, we don't really expect to see anything. And that's great. And for most women, hopefully we won't ever see anything. But it's important that we can kind of see these changes over time, so that if at some point either you feel something or something pops up on a mammogram that looks a little bit concerning, we have a lifetime of images to compare it to, so we know whether to worry and whether not.
Yes. Great point, Lizzie. And also related to that, that's why often your doctor will try to have you get your mammograms in the same place with the same machine, so that we can really compare apples to apples, because we are looking for changes over time. So when we see something abnormal, they will usually then also do So you get a screening mammogram when you don't have any symptoms, where you're just getting a regular mammogram. Once they see something act normal, they'll get a diagnostic mammogram, which is a little more sensitive and it gives us a little bit better picture. And they'll usually also do an ultrasound with that. That allows us to get a sense of what is the size of this mass. Does it look like maybe it's a cyst with fluid in it, or is it more solid? And from there, if it still is looking concerning, they're going to do a biopsy. They're usually going to be sticking a needle into that mass and getting a sample. And the needle essentially has a hole in the middle so that they can get like a core sample of that mass. And so you can see in this picture on the bottom that they're using the ultrasound to help guide them, and then they're sticking that needle in. All right, so now we're talking about the types and the stages of breast cancer. I did mention a little bit about hormones. So whenever we get a diagnosis of breast cancer, so they get that biopsy, the pathologists are going to look at the tissue under the microscope, and they're going to tell us if they see cancer cells. And once they see cancer cells, they're going to do testing on it, and they're going to look at 3 different what we call biomarkers. One of them is the estrogen receptor, one of them is the progesterone receptor, and one of them is a protein called HER2. So essentially, these biomarkers are really just they're sitting on the membrane of the cell, on the outside of the cell. The estrogen and progesterone receptor, as they sound, are basically they sit on the outside, and the estrogen and progesterone in your body can then bind to those receptors and send signals to the cell that cause it to grow and divide. So the cancer is essentially feeding off of those hormones. And then HER2 is a protein that also sits on the outside of the cell. And when it is overexpressed in a cell, it also causes cells to more rapidly grow and divide. So the most common type of breast cancer is what we call hormone receptor positive, meaning it's positive for either the estrogen or progesterone receptor, and HER2 negative. And then the other types of cancers are less common, but about 10% of breast cancers are hormone receptor positive and HER2 positive, and sometimes we call that triple positive. About 10% are triple negative, negative for all 3 of those. And then just about 4% are hormone receptor negative and HER2 positive. We consider triple negative breast cancer and HER2 positive breast cancer to be more aggressive because they are more likely to spread to other organs, more likely to become stage 4. They tend to grow more rapidly. But these biomarkers also give us information about how we treat the breast cancer. So once we have that information that you have breast cancer, we know what type, we also want to know what stage of breast cancer you have to treat it appropriately. And the stages actually go from stage 0 to stage 4. You may not hear about stage 0 a lot. It's also referred to as DCIS, which stands for ductal carcinoma in situ, which I have a picture on the next slide, but essentially means that the cancer cells are staying within that lining of the duct and not spreading anywhere else. It's a stage 4, which we also call metastatic breast cancer, where it's spread to other organs. We try to get as much information about the stage before you go to surgery, right? We get scans, we do biopsies to try to estimate the size of the cancer, whether or not it's spread to lymph nodes or other organs. We want to know all of these things in addition to those biomarkers, and then how the cancer looks under the microscope. And sometimes we will check what's called an oncotype score for these hormone receptor positive, HER2 negative breast cancers. We use all of that information to figure out the stage. And sometimes the way we stage that cancer changes before or after you go to surgery based on the information we have. So stage 0, DCIS, is so up here at the top. When you have the normal milk duct, right, that we talked about in the breast tissue, the DCIS cells are cancer cells that are staying inside the duct. After they invade outside of the duct, we think of it as invasive breast cancer. So it's at least a stage 1 at that point. We think of stages 1, 2, and 3 as early stage because we think of those as curable cancers. Okay, at stage 4, we call metastatic. And that's because the cancer has spread to other organs. And while we can't cure it, we can treat it. And so for people that do have stage 4 breast cancer, about 5 years after their diagnosis, looking at all types of stage 4 breast cancer, about 30% of people are still alive after 5 years. So you can just see here pictures of the breast here and the lymph nodes. The lymph nodes are really glands that go throughout the body. We have collections of lymph nodes in different places in the body, and you can see under the arm is one of the bigger collections of lymph nodes, and it's usually the first place that we see breast cancer cells spread after they leave the breast. And so that is one of the places that we're always checking to see, are these lymph nodes, do these lymph nodes have any cancer in them? How do we treat breast cancer? So I mentioned,
Jump ahead to
yes,
treat.
please.
Yeah. Just we've covered a lot, both in terms of how we grade and stage breast cancer, but also, how we detect it. And so I just want to make sure that y'all don't have any questions. I haven't seen any pop through in the chat, but are there questions or things that we can answer for you about your personal risk, what screenings look like, anything like that?
Yeah, happy to answer any questions.
And we can also answer them all, but I really do want to make sure that this is interactive for you guys and giving you the information that you need. Dr. Smith-Graziani and I can talk about this for hours, but I want y'all to tell us what's helpful and what we can do.
Yes, please. Yes, ask any questions you have. While we wait for questions, so we can talk a little bit about treatment, which, yes. So we talked about how when we think of early stage breast cancer, that's stages 1 through 3, and that's a curable cancer. So our goal here is to cure. And right now, the best ways that we know to cure that cancer include surgery. We want to remove that cancer. It also helps us really finalize that stage of the cancer, right? Because we are making our best guess with our imaging, but going in and taking that cancer out and looking at everything under the microscope is how we know for sure where the cancer is. There are different types of breast surgery that you can have. The mastectomy is when we remove the entire breast. Many people are able to get what we call breast conserving surgery or a lumpectomy, where they're just removing an area of the breast around the cancer itself. And then often they're going to remove some of the lymph nodes under the arm, like we talked about, to make sure there's no cancer there. And then radiation therapy is often a part of this treatment as well. They want to destroy the remaining cancer cells in the remaining breast if you had a lumpectomy, or in the chest or under the arm. Whether or not you get radiation and what type of radiation and for how long really depends on your stage of breast cancer, the type of surgery you had, and your age. But it's usually given after surgery. And then I'm a medical oncologist, so I'm in charge of the systemic therapy, which are all the medications related to your cancer treatment. I tell patients that the surgery is for the things we can see, right? My stuff is for what we can't see. The systemic therapy, as we call it, the medications that go throughout your bloodstream, either in IV or pill form, they're going to go to destroy cancer cells anywhere they're hiding throughout the body, because when cancer comes back, it is because a microscopic cell has broken off that we can't see. It travels through the bloodstream and it hides out somewhere in the body, and then years down the road, it starts growing again and causing trouble. Sometimes we give the systemic therapy before or after surgery. The types of treatment that we use really depend on which biomarkers your cancer has and what stage. But we can use things like chemotherapy in the more traditional form, IV. There's also pill forms of chemotherapy in certain situations. For those cancers that do feed off of estrogen and progesterone, we use what we call endocrine or hormonal therapy, where we lower the amount of estrogen that's available in your body. We can use targeted therapy against that HER2 protein. So we have antibodies and other things that bind to the HER2 protein and destroy those HER2 positive cells. And then for triple negative breast cancer, we're now using immunotherapy, which essentially takes the brakes off the immune system and allows your body, your white blood cells, to recognize the cancer as a foreign invader, like it recognizes a virus or bacteria, and destroy cancer that way.
You know, we're lucky. There's been so much research that's been done, especially for these early stage breast cancers. Your treatment is really personalized. So everybody gets sort of a different flavor of treatment based on the type of cancer they have, the biomarkers of their cancer, where it is in their body. You really work hard to make sure that you are getting the exact amount of treatment that you need, and no more and no less. I think sometimes when we have women maybe who feel a lump in their breast, right, and they are understandably really afraid of what that can mean and what the treatment is, and sometimes that can lead them to delay seeking care. The sooner you can seek care, the sooner that we can help. And there really have been so many incredible advances in treatment. This is a very survivable disease, and the treatments themselves are becoming very manageable.
Yes, thank you. It's a great point. So that's how I treat the early stage breast cancer. Now, when we're talking about metastatic or stage 4 breast cancer, I think what scares folks so much is that we can't cure it. And right now, yes, we cannot cure it, but we can treat it. And we have a lot of good ways to treat it. And so the goal of the treatment becomes not curative, but what we call palliative, meaning that we're trying to keep that cancer from growing. We want to prolong everyone's life with that cancer. And we also want to optimize the quality of life, right? So we want to make sure that we are keeping the cancer under control, but also addressing any symptoms that you're having as a result of the cancer. Usually we're treating it with the medications, the systemic therapy, because that is the treatment that goes throughout the bloodstream and treats cancer everywhere it exists. Sometimes we might use something like radiation if you're having a symptom from a cancer in a particular spot, and we can just shrink the cancer in that spot. But the medications are really the main thing that's going to treat cancer everywhere in the body. And then we also work really closely with our palliative and supportive care team. This is a team of specialists that they focus on managing the symptoms related to chronic diseases and particularly cancer, and not just symptoms from the cancer itself, but the symptoms from the treatment of that cancer. And it's really important. You know, I really like for all of my patients who have stage 4 disease to be seeing someone in the palliative and supportive care department. And we do have data that shows that the earlier you get the palliative and supportive care team involved, the longer people live and the better they do. Okay, so I've dumped a lot of information on here. So I just wanted to kind of wrap up with the idea of what is it that you can do, because I think that's what people are really focused on, like with all of this risk, all of these, you know, issues with breast cancer, what can I actually do about this? And the things that you can do are, one, to try to address any risk factors that you do have some control over. We talked about exercise and weight being a factor, as well as alcohol. And so those are things that you can change, right? Now, a lot of the factors related to breast cancer are things that are not within your control. And so really the best thing you can do is make sure that you are seeing your primary care doctor, go and get your screening mammograms, get all of your cancer screenings, and go in and get your breast exams. You know, there's no longer an official recommendation for doing self breast exams, but what we do recommend is breast self-awareness, right? That if you're familiar with what your breast tissue usually feels like, and that can change depending on where you are in your menstrual cycle and other things, right? But if you learn what's normal for you, then you may be able to pick up something that's changed and bring that up to your doctor. Ask about your screening mammograms. Ask about whether or not you should get genetic testing or talk to a genetic counselor, and be aware of your family history of breast cancer and all cancers. And then if you are diagnosed with breast cancer, I think the most important thing is finding a team that you're comfortable with, because you are going to be with that team for a long time. And so you need to make sure that you feel comfortable bringing up concerns and talking to them, that you feel like that you are listened to, right? Because it's really a collaborative effort here. I always recommend that you bring someone with you, especially to your first visit, more if you can, because as you've seen, it's a big information dump and there's a lot to remember. And you come home and people say, what did the doctor say? And it's hard to remember. So I would bring someone else, another set of ears, just to be there to support. Write down any questions that you have ahead of time. And then we're always going to put in a plug for clinical trials. Please ask about any clinical trials available that might apply to you and your type of breast cancer. We have a lot of great treatments that are FDA approved, standard of care. Those treatments became approved because we had people who were willing to participate in clinical trials of those drugs. And so sometimes we can get patients access to newer, more effective drugs through a clinical trial. And so we always appreciate people being willing to participate in a clinical trial. And then I just have the screening guidelines on the side. There's been a lot of debate depending on which organization you talk to about when to start your getting mammograms. We're a little biased over here. And so I recommend folks really talk about getting a mammogram starting at age 40. Especially if you have a significant family history, but definitely by the age of 45 for sure. Okay, so that I think is it, and we're happy to answer any additional questions anyone has.
That's some fantastic questions in the chat. Dr. Smith-Graziani, and we can kind of talk to them about it. Does that work?
Okay, let's see.
Can you go back to the slide about mammograms and ultrasounds? So I think
Oh, yes.
that's going to be where a lot of our questions are.
No problem. Okay, let me go back here. And let's see. I think we have it.
And just so everyone can know, I'm happy to read out the questions as well in a totally anonymous format. And there was, I think what Lizzie's referring to, there was a specific question about someone who had a mammogram recently. And now they're bringing them back in for a diagnostic and an ultrasound, and they're just wondering what the risks might be.
Got it. Okay. Yes. So this is very common. If they ever see anything abnormal, so this is the radiologist, the breast imaging radiologist, if they see something abnormal, based on the specific appearance, they kind of give it a score. And based on that score, that recommends whether or not you should have additional imaging right away, or if it's something that should be followed and checked again in a few months. So it sounds like they have decided that based on the appearance, they want to follow up with that diagnostic mammogram to get a better look at it, and the ultrasound. Now, sometimes when you get the diagnostic mammogram and ultrasound and they get a better look, they say, actually, this looks a little bit more benign and we'll follow it up. But sometimes they'll say it still is looking a little bit concerning and we'll do a biopsy. Now, as far as like how often that happens, that I don't know for sure because breast radiology is not my specialty. But what I will say is that if they have any concerns about it, right, they're going to err on the side of caution and go ahead and get the biopsy, because a biopsy is always the way we know for sure whether or not something is cancer.
Diagnostic mammogram, it's a closer look, right? So I have a very strong family history of breast cancer. I had my first mammogram. I also got called back for a diagnostic. It can be
anxiety inducing, and I do this every day for my job, right? It was a really different experience for me to be the patient that had to do this. But your screening mammogram looks at all of your, blood tests and all of your breast tissue. The diagnostic is going to be a really specific look at a really specific part of your breast, sometimes taken from different views, or if you'll see in that picture, this the plate that's on top of the woman's breast. So sometimes they'll use a different plate, or they'll move the camera in a different way to try to get a really clear picture of it. And those pictures are how we get a better understanding of what's going on and can really help guide our decision making. So as far as the risk of doing an additional image or doing an additional ultrasound, there really isn't. The risk is in not doing it, right? The risk is in not knowing, so that we don't know the right way to intervene and keep you safe.
So there was a kind of similar question along the same lines in here as well, that somebody asked, when does the doctor decide to do an ultrasound when you have dense breast tissue?
So it's usually, if we need anything besides a mammogram, the breast radiologist usually makes that recommendation as part of their report. Now, for people who often have really dense breast tissue, sometimes they may recommend an ultrasound, but sometimes they may also recommend that you get a breast MRI as part of your screening, which can give us an even better picture. We usually do breast MRIs and breast mammogram and mammograms for patients who we know are at a higher risk of breast cancer, based on family history and their personal history. But sometimes in the setting of very dense breast tissue, they may recommend additional imaging in the form of an MRI or an ultrasound. So usually you're going to see it in the report when you get that mammogram. They actually, in the same way that they give a score to how the any mass might appear, they also have ways of, they have specific language they use for the density of your breast tissue. And so from that, they're able to make a recommendation as to whether or not you need additional imaging to get a better idea.
We had another question come through in the question and answer functionality. Somebody asked, how often do you see women under the age of 40 get breast cancer? And should they get a mammogram before the age of 40 if they have two cousins who have had breast cancer?
Yeah, that's always really tough. So most breast cancers are still diagnosed in women who are in their 50s to 60s. However, I did mention that we have certain populations in the US that are diagnosed on average at a younger age, Black women, Indigenous women. And also when it comes to family history, usually we're looking at what we call first degree relatives. So we're looking at parents, siblings, grandparents, children. We also look at secondary relatives like aunts and uncles. When it's just cousins, it's a little less of a strong connection. However, I think it's always helpful to talk to a genetic counselor when you have a concern, because that's really the underlying concern. Is it an inherited form of breast cancer? When you do have one of those first degree relatives that was diagnosed at a younger age, sometimes you'll get a recommendation to start screening about 10 years before they were diagnosed. And so that will sometimes get you under the age of 40. There is a lot of debate right now about the best age to start and how frequently to check mammograms in the general population. So people who don't have additional risk factors. And that's because there is, a rate of false positives, right? Where people get abnormal mammograms and have to get a biopsy, which is not pleasant, only for it to come back negative. And so people are sort of weighing that against the benefits of us finding breast cancer earlier. And so you'll hear a lot of differing opinions on that. But what I would say is, one, talk to your doctor. The 10 years before a close family member is diagnosed is always a good rule of thumb, but then also ask about seeing a genetic counselor to then see, based on your specific family history, do you have a risk for an inherited form of breast cancer? And then would would testing be recommended?
I think you can also, focus on the things that you can control, right? So doing, and that's so much easier said than done.
Right, but doing what you can to exercise, to eat a healthy diet, to care yourself, but particularly for you. The breast self-awareness that Dr. Smith-Graziani was talking about, right? So we know that breast tissue changes normally and naturally throughout the course of your lifetime, but also day to day and week to week over the course of your menstrual cycle. So really try to get very familiar with what your breast tissue feels like, and your breast tissue goes all the way up to armpits, right? But really know, when you're in the shower, know what that feels like, and then you'll know if something changes.
I saw, Lizzie, you had mentioned in the chat as well, if it would be helpful to maybe talk about clinical trials a little more. I think that would be great if you all just wanted to touch on that briefly, kind of, I know there's a lot, like you said, there's a lot of misinformation out there and people are, not really sure what that always means. So if you all could touch on that for a bit.
Absolutely. Yeah. It's definitely something that Dr. Smith-Graziani and I are passionate about, particularly in looking at access to care for underserved communities. When we go back to the slides that talk about, for women of color and for Indigenous women, they tend to be diagnosed later. They tend to have poor outcomes, and those are absolutely multifactorial. But broadly, clinical research can help us understand and answer some of those questions at both the personal and population level. Diversity in clinical trial enrollment is definitely something that we are actively looking to improve, and we know that as a country, as a state, we don't have a great track record of caring for minority populations historically. And so for things like they're not often diagnosed with more aggressive disease, but is it about that? We really have a lot of scientific questions that we're hoping to answer, and I think that clinical research is a way that if you are diagnosed, I think for a lot of my patients, it provides a lot of meaning to their experience of illness, knowing that what they're doing doesn't only impact them, but can impact the lives of others, impact the lives of the treatments or better diagnostic tools for others. But joining a clinical trial also often means that as a patient, you get access to first-line treatments, right? To treatments that are not available to the general public yet, that are kind of at the very forefront of cutting-edge science, and we've seen some really fantastic results. As Dr. Smith-Graziani said, everything that patients are prescribed now is because of clinical trials that approved them. So the way that clinical trials work in our country is that if you have a new drug or you have a new diagnosis, you start testing it on a very, very small group of people. And then once you've proved that it's safe and effective for a little group, then that group gets bigger and bigger and bigger. And over time, those treatments become what we would call standard of care, which is something that everybody has access to. So if you are diagnosed, please do ask, whether that's coming here or contacting me or asking a provider. But we really want you all to have access to that. I think one of the most common misconceptions that I hear, Dr. Smith-Graziani, I'd love to hear your thoughts on this as well. I have a lot of patients that understandably believe that if they join a clinical trial, there's a chance that they would get a placebo. There's a chance that they will not get chemotherapy at all. That is not the case. That's unethical. We could not and would not ever do that. But because of the way that clinical trials are portrayed and history and other things like that, that's a really reasonable understanding to come in with. So you don't. Typically, a clinical trial would compare the standard of care, so that everybody would be doing, compared to so you would try to see which of the two groups is going to do better. What are we seeing in the underlying biology of the cancer between the two groups of folks and the two sets of cancers? But yeah, Emory is a large research institution. We've got clinical trials available for every type of breast cancer here. And that's true of a lot of places in our city as well. So if this is a part of your journey of breast cancer, is something that's in your history, we would love for clinical trial participation to be something that gets as well.
Yes. And if for information on clinical trials throughout the country, you can always go to clinicaltrials.gov. And you can look up by type of breast cancer even, and see what's available here at Emory, but also elsewhere in Georgia and elsewhere in the country.
There's one more thing that I realized we meant to include and did not, which is that men can get breast cancer. We default to saying women because that is the bulk of our patient population, but it is not solely a woman-only disease.
Yes.
And because of that, we often see delays in men or people who were born male or assigned male at birth. There's often a delay in seeking treatment because it just doesn't register as something that a male presenting individual could have. But that is the case. We do see that sometimes with the family history, but sometimes not, just like the other kinds of breast cancer. So if we do have any men in the audience, I want to acknowledge that that is something that unfortunately everybody is at risk for, so please do be aware of that. Yeah.
Great point. Yeah.
I know we have just a few minutes left. Again, everyone, please feel free to use the Q&A function, the chat function. I saw somebody had just raised a hand before. I don't know if that was on purpose or not. But I think also just to include information as well in terms of resources. So I know a lot of folks on here are probably familiar with Emory Healthcare. We're, you know, a larger healthcare system in Metro Atlanta. And Dr. Smith-Graziani, you practice at our Clifton Road campus as well as our newer campus at Midtown. I think if you could just kind of speak to, you know, kind of where resources are in the Metro Atlanta area and options that people might have for, you know, if and when they need to seek care for breast cancer, kind of what is out there for them.
Definitely. So within Emory Healthcare, in addition to the Clifton Road campuses in Midtown, we also see patients at St. Joseph's Hospital. And then we have our general oncology team within Emory. So these are oncologists that see all different types of breast cancers, not just breast. And they are at these other affiliated Emory sites like Emory Decatur and Johns Creek. Outside of Emory Healthcare, so Emory physicians go to Grady Memorial Hospital, which is, as everyone probably knows, our county hospital. And so for people, especially if we're having concerns about insurance, Grady is a great place to get treatment by Emory physicians. We also open our clinical trials there when we can as well. And then outside of Emory affiliated folks, you know, there are multiple hospitals in the Metro Atlanta area and private practices as well. We work with those breast surgeons, breast oncologists, radiation oncologists throughout Metro Atlanta and even throughout Georgia. So oftentimes people will get their treatment started out in the community. And then if they come for a second opinion, have a question about one of the clinical trials we offer, they'll come and see us and we work with their oncologists. So it's a team sport. I think being seen where you can, we're lucky in being in a large city and having access to all of these resources, but never be afraid to get a second opinion.
Yeah, I think it's so important that you feel comfortable and confident in the treatment team. For my patients, there's really no room for hurt feelings. If working with me is not doing it for you, that's okay, right? Like, I would love to help you find another person, but you're your own best advocate. And so if you want a second opinion, get one. I would say most oncologists really welcome that, right? As practitioners, we ask second opinions from our colleagues all the time, right? Hey, I've got this patient and they have this, this, and this. How would you think about it? What would you do, right? Our goal should be always taking the best care of the patient that's in front of us. So if something doesn't seem right and you are just curious, please keep looking, find the right person, reach out to us. We'd love to help matchmake you with the right person. But just, you always want to make sure that you are working with somebody that you feel confident in and that you feel like you can ask questions.
Yes. Okay. I want to make sure. I know we're kind of out of time. Was there anything else in the chat?
So I did not see anything else come through the chat or the Q&A.
Okay.
And I know we are at time, so just to be respectful of everyone's time this morning, Just wanted to say thank you again to both Lizzie and Dr. Smith-Graziani for taking the time to speak with everyone this morning. This is incredibly helpful information. I know a topic that can often be scary and, not so fun to have to talk about. But just to hear this information, the reminder of all the resources and, the advancements that are out there within Emory and elsewhere is just always really great to hear. So yeah, and wanted to say thank you to all of our attendees for joining this morning, and for all of the school district employees. Please keep an eye out. We will be announcing both our November and December speakers and topics within the next week or so. And again, feel free to, hopefully take this information, share your feedback with us. We would love to, continue to provide the best, most helpful information for you all. And I see Lizzie just dropped her email in the chat as well. So folks are welcome to have that and save that. And yeah, that is all we have for today. Thank you all so much. And look forward to talking soon.
All right.
All right. Take care.